All right. First of all, I want to thank you all for being here. And what I'm going to do is I'm going to present a case. This was a case that was done just this week. I've learned quite a bit, and I would like to hear your input as well. And at the outset, I would like to thank Dr. Graham, Joseph, Ravi, Roy, Selvi, Sylvia, and Sriram and Aman. Thank you so much. So this is something that we're trying. If you want to just have a little bit of fun, you can actually go to the poll EV on your phones. If you want to try that, it's worth trying that. So open your phone and go to Safari and put a poll EV. And then you can put a GSR 977. So that would allow you to join the poll. And actually somebody has already put in the poll, it looks like. And you can place actually where you live so that we have a feel for where we are. Mm-hmm. Okay. All right. Hope you're able to get in there, and I hope it's not too difficult. I see Ravi from Singapore. I see Sylvia. Yeah, all right. Actually, this is a very interesting program to try. And if you want to get your CME, I would request you to text. If you have registered to the MD Anderson CME program, you can actually text that so that you can get your CME. And let's take a minute to do that so that we all get our CME. So 251. All right. So this is a patient that I took care, and it was a patient that I felt sad that I couldn't take care of her well, but I wanted to hear your input. So this lady is in her late 70s. Her mother had colon cancer in her 80s, and she had a colonoscopy 10 years ago, and she had colon polyps. And it's very interesting. I was digging through her chart from everywhere, like now that we have access to those records. And it's also interesting that, so despite that history of colon cancer in her mother, and in her case, 10 years ago, colon polyps, what I don't know is the type of polyps. And she had a Cologuard test that was positive. And then she also has multiple medical problems: atrial fibrillation, coronary artery disease, pacemaker, and she had diabetes, hypertension, chronic kidney disease, hypothyroidism. Last year, she had undergone cholecystectomy. So let me just stop here and ask maybe Sylvia or Selvi to comment the role of Cologuard in a situation like this. Sylvia, what do you think?
Yes, I think that this lady who had colorectal polyps in her medical history would qualify for further surveillance with a colonoscopy, but I don't see much detail about the number and severity of the polyposis in the past. So maybe she had just a few polyps which have been removed, and now follow-up has been recommended. So in this case she can still get the advice to undergo a fecal test.
Mhm.
She's an average risk patient. She has one first-degree relative with colorectal cancer, but very old, at older age. So I think she's an average risk patient.
Yeah. I wish we had details about the type of colon polyps, and that would have helped us. If we had adenomatous polyps, then obviously she should have had a colonoscopy straight rather than a Cologuard test. On the other hand, if she had average risk with polyps, but not necessarily precancerous polyps, then the question of a Cologuard test. And at the same time, she is in her late 70s with so many medical problems, that also one needs to take into consideration.
Yes, I fully agree.
Right. So she had her colonoscopy, and she had her colonoscopy in March, and at an outside facility. And the report says she had basically 3 polyps in the right colon, 25 millimeter polyp in the cecum, a 30 millimeter polyp in the cecum, and a 15 millimeter polyp in the IC valve. And when the endoscopist was planning to do the resection, they noted the pacemaker dysfunction. And because of that, they decided to hold off. And instead of going back to the same endoscopist, she went to another endoscopist a month later. And she was found to have, the colonoscopy report says in the vicinity of the cecum, there is a large carpet-like lesion that is about occupying about 50% of the circumference, flat and carpet-like. And the endoscopist reported that it is not amenable to endoscopic resection. So I'm sure she was advised to have surgery, but then she decided she wanted another opinion. So, she's in her late 70s, already had 2 colonoscopies in the last 2 months. So I saw her, and we did the procedure just this week, actually. And she had a very long, tortuous colon with a lot of looping. And it took almost 15 minutes to reach the cecum. And this is what we see. And before I say that, I want to ask the group, how often do you normally describe in your report the difficulty to reach the cecum in your endoscopy report? Let's take a poll and see. Can you guys see the poll already?
Yes.
Okay, okay. Yeah, it's good. I think I wish I could give you the number there. I don't have the access to the number, but whoever responded, it looks like a lot of us do report the difficulty. I think that's good. Sorry about that. I need to stop sharing and need to do this thing a little bit different. So just bear with me.
Does it get stuck or?
Yeah, I think I need to do a little bit different. Okay. All right. Okay, let's try this one. So once you reach the cecum, how often do you describe access to the lesion for EMR? Easy or challenging? So just need to see whether you normally say, okay, the EMR access to the lesion is easy or not, or whether it is difficult or not. So the reason I wanted to ask these two questions is, say, for example, we see a patient and then we decide that for some reason we back off saying that, okay, there's a problem like in this lady, pacemaker problem. It would help the next guy, if in case the patient goes to another endoscopist, the difficulty faced by the first endoscopist in terms of reaching the cecum and also the access to the lesion in terms of planning. And there's an interesting paper by Michael Burke's group published in Gut a few years ago, where they include that they report that it is advisable to report both access to the lesion difficulty or not to plan your resection in terms of the time you will need to set up for the procedure, and then in talking to the patient whether you'll be successful or not, and thirdly, if a complication were to happen, whether you can manage that or not. So that is something to keep in mind, and especially if you do the resection, it's good to say whether it was easy to access. If you decide not to do the resection, it's also good to say that, so that the next guy who's trying to take care of this lesion will use that information to counsel the patient and come up with a better plan. So something that might take an hour, if the access is difficult, you may need to set up for 2 hours so that you're not under too much pressure to resect that lesion. So, all right, that's good to hear. Okay, so let me play this video. So we reached the cecum. It took about 15 minutes, and I'm going to play this video, and I want maybe Sriram to comment.
Sorry, sir, I am driving, so
Okay,
I won't be
all
able
right.
to focus.
Okay, don't do that. Don't do that. How about, let's see. Aman, you want to comment?
I'll try, sir.
Okay, all right.
So, I think I can see the IC valve on the right side, if I'm not wrong.
Yeah.
And there seems to be a polyp that's starting almost at the IC valve, or maybe involving partially the surface of the IC valve and going along the circumference to the opposite side. It seems literally spread, like a literally spreading tumor, and probably I haven't seen the NBI imaging, but probably like a granular type. I'm still not very clear on where the polyp starts and where the polyp ends, because I have seen some water coming in there and some views, but I don't have a very good idea as to the whole size of the polyp yet. And this is a little bit more clear. So I think that's the appendiceal orifice. So it's almost going towards the appendiceal orifice, starting at the IC valve. It seems like it's probably involving 40–50% of the circumference. And seems like it has some depressed portions and some on the other side of the fold. And probably involving, couple folds, and also it is probably on the distal side of the fold as well, coming below the fold, I think.
So Aman, what I've done is once I got in there, I did not edit this video. I just let it run. So you're going to see see those three polyps. One, that's the appendicular orifice. There is one polyp here, and the one that you saw, this is the second polyp in the base of the cecum, right here. And then you have, if I go back, as you mentioned, it's on the ileocecal valve polyp here. One of the things is we should actually, when we describe the ileocecal valve polyp, we just say a polyp on ileocecal valve. Instead of saying that, it's a good idea to describe. It's a good idea to describe the polyp, whether it's on the lip towards the appendicular orifice. You can describe that as the inner lip and outer lip, and then the extent of the polyp involving the valve, how much does it, and then also describe whether it's going into the appendicular orifice. So let me actually take you to the next clip, and you can see the NBI. And before you see the NBI, you can actually see the definition of the polyps a little bit better. So that's the appendix opening. The ileocecal valve polyp is not going into the ileum. And you have a little bit of a better view of this IC valve polyp. So I must share with you that when I was seeing this lady in the clinic, I was under the impression that I was dealing with a 15 millimeter polyp and a 20 millimeter polyp and a 10 millimeter polyp, because the reports that came to us were scanned reports. And when you have a scanned report that you try to access from the electronic medical record, I actually mistook that at 30, the 3 actually was blurred out, and I thought it was a 10 millimeter polyp. And it was interesting when I was talking to the patient and her husband that we should be able to cut it without difficulty because they were not big polyps. But when I started the case, I really struggled to get to the cecum. And then to look at this polyp now, the one that is I'm looking at, my up-down is all the way down, and my right-left was all the way to the right, maximally deflected. And even with that, I was not able to define the polyp true extent. And I could see the right edge, but I could not see the left edge. So that's one thing I wanted to share with you. And let me take you through the NBI, and let's see. Let's hear from Sylvia, her thoughts. And you can see that, Sylvia? You would like to
Yes.
comment on that? Yeah.
Yes, I think it's very interesting that the first two endoscopists disagreed about the description of these lesions. Uh, Actually, the first endoscopist, if I'm right, described three lesions, two in the cecum, the third on the ileocecal valve, and the second one described a very large lesion, a laterally spreading tumor, probably over 50% of the circumference. In my opinion, I see normal tissue between the lesions, so I think that there are multiple lesions and not one large lesion. But in this particular case, we have been discussing many times about the role of selective chromoendoscopy. I think um, chromoendoscopy would be really helpful to demarcate the borders of the lesions. Are we dealing with three separate lesions? This one you have now in at 6 o'clock. This seems to be the largest lesion, and all three look to me like laterally spreading tumors, granular homogeneous subtype. I don't see suspect concerning areas. I don't see expansion, retracted converging folds or depression. But I think in this particular case, I would apply indigo carmine just to get a better um, mental representation of the lesion.
Yeah. All right. So one of the things that I tried to define was whether these were separate or not. Just as you can see, this lesion on the cecum actually close to the appendix ends here, and there is a little bit of maybe 1 to 2 centimeters gap, maybe a centimeter gap between the lower border and then the second lesion in the cecum. And the problem that I had was the second lesion in the cecum, I could define this area better, and the area onto the left side of that lesion, I was not able to define despite my scope tip deflected all the way down and all the way to the right. That's the maximum deflection I could get. And so at this point in time, I felt that although I could cut this lesion and I could cut this lesion on the ileocecal valve, I will not be able to cut this lesion. And interestingly, when I saw her, she said, "Hey, I have received already, this is my third colonoscopy, and I don't think I have any patients to go through multiple exams. Hope you can take care of this in one shot." And I told her that, hey, given the pictures that I saw, I underestimated basically the true extent of this lesion just beyond the ileocecal valve. I thought it was a 10 millimeter lesion, and I told her that we should be able to cut. I was a little bit disappointed when I saw this large lesion and my difficulty in accessing that lesion completely. And then you have to keep in mind, she's in her late 70s with hypertension, diabetes, chronic kidney disease, atrial fibrillation, blood thinners, everything. So,
Raju,
yeah,
sorry, I don't have the right link. So I'm using Ravi's link. So I'm Ravi today.
okay.
Ravi number 2, I think. It's so much easier if you just use Indigo Carmine to image. So
Yes.
this NBI to look at the borders and things like that gives you a headache.
Right.
And I think even our colleagues elsewhere in Japan, they're going back towards using the chromo to just image it for something like this. And it would be very clear where the border is. There are 3 lesions, and you have to decide how you're going to cut it, whether it's 2 sessions or 3 sessions. And many people will say, well, it's probably too risky to do endoscopic treatment, but then they think that surgery is not risky.
Right. Right.
It's all benign so far that you've shown us.
Right. It's all benign too. So I wish I did the chromo. I think that is something I should have done, but having looked at it carefully and I could not define the left border, then this is what I've done. I'll show you something. So here is the lesion on the ileocecal valve, trying to define it a little bit better. And at least it did not have any features that are worrisome for cancer. And the lesion on the appendiceal area also is the same. So let me just go to the next one and see. So bear with me. I think it's okay. So at this point, you know, one of the things that happened was I realized as I was doing the exam, in between, my scope kept slipping back. You know, when I slipped back all the way to the hepatic flexure. And I thought that I may not be able to cut her, first of all, completely. And the second one is if I cut with an unstable position and end up in a bleed or whatever, at her age, it will be a disaster. So I actually, for the sake of junior colleagues, I want to share with you, it's probably a good idea to bring the family member into the room so that they can see what you're seeing, because the pictures don't tell the whole story. And I brought her husband, and then at that time, I basically turned to examine that lesion just beyond the ileocecal valve. And as I was doing that, you can see how often I slipped back, you know. This is that second lesion, which is almost 40 to 50% of the circumference. And even though now we're able to see a little bit better, as you can see, right? You know, this is an unedited video. You keep slipping back, keep slipping back. This is, I felt that I would not be able to safely cut without ending up with a problem. And the fact that it was very difficult to reach the cecum, 15 minutes is quite long to go in, because the number of loops I reduced. Usually if I form a loop and I reduce, you know, I try to put it onto the umbilical cord and then take the scope out. I must have done at least 2 or 3 times when I had to disconnect the scope to take the loop outside the patient. So at this point, I decided that I will not be able to safely cut her polyp. And I'm planning to send her to surgery. So I wanted to hear your thoughts, what you would guys do in a situation given the findings that you have, and how do you approach somebody like this?
Is this the one situation where shape lock is a good application for?
No, I think actually it's a good idea that you bring that up. The problem with the shape lock is it's about 15, 16 millimeter outer diameter. Right now, that one that we have, and her left colon, she has quite a bit of diverticulosis, and quite a loopy colon. And the caliber of the colon was not a wide bore colon, right? It was quite narrow colon. In that case, I don't have much experience. I have experience of n is equal to 1 in somebody who had a wide bore colon with a long loopy colon. In somebody with diverticulosis, severe diverticulosis, angulated fixed colon, I don't have the experience to say whether that would make it any easier in her case. But I think that's a good thought to keep in mind. Any other thoughts? Selvi?
How about just leaving it alone?
Yeah, actually, she has so many comorbid conditions, right? Her health-wise, and this is looks benign. The question is, what is her expected lifespan? She is late 70s, nearing 80s, and that is one option that one could consider. And the way I'm planning to do is get her seen by a surgeon, look at her surgical risks, and then decide whether we should wait and watch. Or if she feels uncomfortable, then go for surgery. I think that's an option that we should always keep in mind. Dr. Graham, what are your thoughts?
And I would be on the fence like you. And the patient has to make the decision. But
Right.
Shared decision, yes.
Right. Yeah.
Way to go.
Right. I'm just
I
wondering.
have a quick comment.
Yeah, Sriram, go ahead.
So I think this is I think what I would have done, what you have done, maybe half the time before, because of the situation of not being able to get there and stay safe. And these 3 lesions in that area, with all her risk factors, is too much of a risk for endoscopic resection, requiring, for sure, if at all somebody develops a post-polypectomy bleeding, she has all the risk factors for that. And on the other hand, as you were presenting, I was also thinking in terms of the risk mitigation versus leaving it alone, like Roy was suggesting, which is that did cross my mind. Why are we bringing her risks forward? But here is the counterpoint for that: is that if at all, considering all her risks, if at all she can survive a surgery, if she would survive surgery today, likely to survive surgery today, then a couple of years down the line, when it will turn into a cancer and the lesion is near the IC valve, and if that causes a cancer and an obstruction, then you cannot get away from surgery, from either from curative intent or palliative intent. Whereas if they do surgery at this time, balancing the risk, cardiac risks and the age-related risks, a right hemicolectomy now is relatively speaking more safer now than in future. That is the argument for convincing the patient to at least go to a surgeon and have a conversation. And even otherwise also, because if it is endotherapy means that we are guaranteeing at least another colonoscopy after the resection, at least one, but probably many. So that is what also we are saving by talking to the surgeon at this time than in future.
Yeah. So I think for the sake of my junior colleagues, I think I wanted to share one thing that's important. And I'm glad that Sriram brought this approach of letting her see surgeon, and if she goes through surgery well, she will probably come out good. So keeping that thing in mind, as when I decided, actually after I brought her husband into the room and show him what I was seeing so that he could appreciate better, then what I did was I basically examined her entire colon as if I was screening her for the first time. And she had one other polyp in the ascending colon, about 2 folds above the IC valve. I did not remove that. It looked small. I photo documented. It was an adenoma, classic adenoma with NBI findings of an adenoma. And then the rest of the colon, I saw one flat lesion in the sigmoid colon. It was a 6 millimeter, 7 millimeter lesion, flat, like almost you feel like it's a flat 2B lesion. And I did an EMR on her. It's very interesting. Her sigmoid colon was so floppy and moves all over. It took me a while to actually clip that defect. The reason I wanted to clip the defect is because of her age, her chronic kidney disease, and her anticoagulants. Although literature says that clipping is beneficial in the right colon and not so much in the left colon, even though with that information, when you have somebody who's older, age is a big risk factor. And the second one is anticoagulants is a big risk factor. And in some studies, hypertension is a risk factor for delayed bleeding. And as you know, that chronic kidney disease with platelet dysfunction adds to the problem as well. So with those things in mind, I decided to close. And that closure should have taken less than 30 seconds, to be honest with you. But I struggled because the colon keeps on moving like a flag. And it's very interesting while I was doing that, thinking about if a complication were to happen in her, it would have been a mess. So I was actually planning to, I had a long chat with her and her husband in the recovery room for almost 10-15 minutes. She was quite disappointed. And I told her that, one thing is we have not lost anything. When I say we have not lost anything, trying to do a procedure that's going to be incomplete, and people think that they have had a procedure and they feel that it was done, but it would be an incomplete procedure. And then there is a risk for bleeding, and then she would require a surgery eventually, right? Given these things, I told her that we have not lost anything. And I told her that we screened the rest of the colon. And I actually put it in my note that she does not require another colonoscopy in the next 6 months or 1 year like we typically do. I told her that we could look at her 3 years down the road. So, and that's something I decided to do to just spare her from another procedure, which will normally, it would happen as a matter of routine, but I wanted to make the commitment for her.
Now, what about the Cologuard? Was it positive?
It was positive, yeah.
Now, how do you deal with that information? I mean, because you have to say, well, that was a false positive, or you say that was a harbinger that there's more in that big lesion that you found than you could see.
So I actually did not include a biopsy of that big lesion that I took. I'll get the results. So we'll find out about that pathology of that result. Yeah.
Professor Raju, just a very quick question. I assume that the surgeon will perform laparoscopic surgery in such case.
Yeah. Yeah.
Okay.
Yeah, that's the goal. I think
Mhm.
to consider laparoscopic surgery. Yeah. Any other comments? I just want to hear. Actually, I didn't have a chance to look at the chat. Joseph?
Maybe I have a short comment.
No, I agree with all the points that are given so far. Thanks.
Yeah. So actually, I see that Joseph has put I like probation's difficulty menu section. One of the things that we actually say, for example, when we are doing colonoscopy, right, when we see patients and then we follow patients, most of us, when we are preparing to do a list of cases, we go through the chart. But, you know, I don't go through the whole endoscopy report. I basically look at the impression to see. And it's a good idea for us to get into the habit of putting in the impression, at least the cases where the cecal intubation was technically challenging. I think it's a good idea to include that. And the second one is to also get into the habit of including the type of scope that you would recommend based on your experience of taking care of that particular procedure. So I try to do that in the future, use either a pediatric scope or an adult scope. And sometimes we may think in a woman, they all need a pediatric scope, but some women may need an adult scope if they have a long loopy colon and with a wide bore colon. So for the sake of my junior colleagues, it's a good idea to say the difficulty in your final report, to keep it in mind, and also to comment on the type of scope you would prefer in the future exam, so that when you're preparing, you don't have to go through the report. Most of the reports, anyhow, you may not have time to read the entire report.
And on our software for Provation, there's also, it lets you kind of sort of grade the level of difficulty. Is it somewhat difficult, extremely difficult, and what maneuvers you took to actually overcome that difficulty. So I at least try to make a consistent attempt at reporting that too.
Right. Yeah, you're right.
May I have a short comment?
Yeah, please.
The British Society of Gastroenterology guidelines included a scoring system to determine the complexity of a polypectomy, which might be useful in practice to differentiate between patients who in the end will still need surgery. They call it the SMSA score, which stands for site, morphology, size, and accessibility of the lesion.
Right.
And I have briefly looked to the points. I think this lesion scores very, very high because the site is cecum, which scores the highest. Morphology is flat, and this scores again highest on the scale. Size is large, although it's not a unique lesion. There are 3 large lesions, and of course accessibility is very important. So I think this is a good clinical tool to assess the difficulty, at least for those endoscopists who don't have enough experience and would consider referral to another center or surgery.
Right. Actually, I'm glad that you brought this thing up. That was a paper that I was referring to in terms of accessibility. And after reading that paper, I actually started incorporating into my practice of including the difficulty in the report. Ravi, any comments?
No, sir. No, nothing to add.
All right. All right. Let's request Sylvia to summarize our take-home message. Thank you, Sylvia. I really appreciate your beautiful commentary and the summary. So why don't I leave it for you to summarize?
For me, this was a very nice illustration of decision making, what is the best endoscopic resection in this case. And as we have previously done, we took into consideration 3 categories of factors. We were looking to patient-dependent factors, endoscopist dependent factors, and environmental factors. Patient-dependent factors were this patient had was in her late 70s, so older age, and she had cardiovascular comorbidity. She was an average risk patient. She had colorectal polyps in her past history. With regard to the lesions, these look like benign lesions, although they are quite large, and as we have discussed, they altogether site morphology, size, and accessibility make the case of a complex procedure. So the patient-dependent factors have been carefully evaluated. Then endoscopist-dependent factors, which are always very important. We have learned that even very experienced endoscopists can decide to refer the patient to surgery when all these factors are favoring a high-risk procedure, and it is very important to perform shared decision in these cases. Some patients may still prefer endoscopic resection, even if they have to come back a couple of times to ensure radicality of the resection, but some of them would say, "Doctor, please refer me to the surgeon. I want to be, I'm done with these polyps. I just want to get rid of it as soon as possible." So the patient's decision is very important. Yes, I think that's a beautiful illustration how to decide in our daily practice, how to take decisions.
Thank you so much, Sylvia. You summarized it very well. And one of the things that I started doing in the last few months is whenever a patient comes to me for EMR, as part of my impression and evaluation, I'm trying to use this thought process so that when somebody reads the note, at least they get a feel for about we have considered all the different parameters into assessing somebody's risk and also the benefit. I think it's a good idea to get into the habit of taking the different issues into consideration as part of our evaluation. I really appreciate your.
Raju, I have a question.
Please.
So we often assume that the risk of surgery is like less than the risk of endoscopy these days. We get confused. But a long time ago, we used to use the Goldman criteria for assessing the cardiac risk index for these patients. And I'm just like looking up, like if you plug in even like the most conservative risk of death, MI or cardiac arrests from surgery that we propose is at least 10%, and that's very conservative. I mean, you know, it's like, what are we trying to do? I mean, this is an almost like an 80-year-old lady that has a benign lesion. There is no depression in the lesion, and all of the features are all benign. Yeah. I mean, somebody's going to kill her this way. I mean, I guess it's better to be dead trying, or is it better to be alive and not trying? Right. I'm confused.
I think, first of all, Roy, I'm glad to bring that up. And what I told what I told my patient and her husband is, let us figure out and evaluate your risk by seeing a surgeon, what he reports, and keep me in the loop so that I will help you think through the process, and then decide. You know, sometimes what happens is, as physicians, we say, okay, we can't do it, let's give it to the surgeon and let the surgeon deal with that, whatever. But I think it's important for us to still be part of our patients, to be helpful to the patient, to let them think through the process, right? I think I'm glad that you brought that up.
I completely agree. I think as endoscopists, we could give them the perspectives that look, you're not going. Most likely, you're probably not going to die from this. This is not going to be the cause of death.
Right.
So
yeah, it's a tough call, and that's why I brought this patient. To me, one of the things I felt that as part of the weekly meeting is to present a case and use that information to help take care of the patients that I take care of. And hopefully this discussion will help for somebody else who's dealing with a similar problem.
yeah, thank you. Agreed.
Just a short comment regarding the third option, to leave this lesion in place. Well, this is another very interesting discussion. From a technical point of view, these lesions, the LSTs, granular homogeneous, we have learned have the lowest risk to contain submucosal invasion, but in the international experience shows that these are the patients who come back in 3 to 5 years with post-colonoscopy cancer. So if this lady survived so many cardiovascular events and she will still get, before her 80s, she will get colorectal cancer, will die of colorectal cancer, that's also not ideal, to say it like that. So it's a difficult decision, and I fully agree that the patient should be informed, and it should be a shared decision.
Yeah. What I'll do is I want to actually not just present a case like this and not give the feedback, and I'll keep this lady in mind, and maybe down the road, whenever she makes a decision, I'll give the feedback. I think that's one way we can actually learn better.
Mm-hmm.
Any other comments, questions? All right.
Thanks a lot.
I want to thank everybody. Really appreciate it. Thank you so much.
Thank you so much.
All right.
Thanks a lot.
Thank you. Bye-bye.
Thanks. Bye.
Bye-bye.
Thank you.